Hi everyone, thanks for listening to my presentations. Thanks for listening to the first chapter of tuberculosis, where we'll deal with epidemiology and pathogenesis. Today we'll be handling screening and diagnosis. Okay, sit back and let's go. To eliminate tuberculosis in 2035, as World Health Organization has released the target, we must be able to diagnose active tuberculosis. We must identify latent tuberculosis and treat appropriately. Just a quick recap here. At first, Mycobacterium tuberculosis is acquired through droplets, aerosol, coughing, sneezing, singing, you understand, and even speaking like I'm doing right now, although I don't have TB. Then cellular immunity will contain it, but remember HIV will not let that happen. The infection can then remain latent or cleared off. The individual will be asymptomatic when it is latent, okay, or non-infectious. But the latent TB can become active later on, maybe due to old age, decreased immune condition by anything, than chemotherapy, cancer, diabetes mellitus, radiation, old age, malnutrition, glucocorticoids, HIV, and so on. Detection and treatment of latent tuberculosis infection will save the patient because once it is detected and treated, then you don't have any fear of reactivation, okay? And the general populace that will be affected if the activation is here and person is coughing and the aerosol is all over everywhere. We can only diagnose latent tuberculosis infection with tuberculin skin test or interferon-gamma release assays. There are situations when we'll end it with tuberculin skin test, or we might need interferon-gamma release assay, or we go straight for interferon-gamma release assay. Then, depending on our finding, we might have to exclude an active TB. It is now wise to also screen for HIV from day one. So while we're screening for latent TB, let's screen for HIV as well. What are the indications for screening? Because it's not everybody that should be screened. It's not everyone going along the street that will be grabbed, hey, you need TB screening. It's not going to happen. So contacts of active pulmonary tuberculosis. Maybe someone in your family had been diagnosed with active pulmonary tuberculosis, you need to be screened. People that are doing drugs, IV drug users, homeless people, prisoners, healthcare workers serving in prisons and homeless shelters, visitors to endemic regions, HIV positive patients, immunosuppressed patients, maybe those that are on immunosuppressant for transplant or chemotherapy for cancers and so on. Indications for screening continues to include silicosis, patients on dialysis, those on tissue necrosis factor alpha inhibitors, diabetes mellitus, those on steroids for a long period of time, for example, those on systemic glucocorticoids. If you are suspicious of latent tuberculosis infection and the individual is having low body mass index, or you are suspicious of latent tuberculosis infection and the individual is a heavy cigarette smoker, or you are suspicious of latent tuberculosis infection and the chest X-ray reveals a solitary granuloma, then the individual should be screened. People with past tuberculosis with possibility of reactivation should be screened. And of course, government health policy in your jurisdiction. After making your selection, what's next? In many cases, the initial test is tuberculin skin test. If the tuberculin skin test is positive, don't worry, there will be some representation details that will be given as per all these screening tests. So if tuberculin skin test using purified protein derivatives or RT23 is positive, and you don't want your license to go for it or anything, confirm with Interferon-Gamma release assay. Also rule out active TB with history, physical examination, X-ray, and so on. If tuberculin skin test, that is mantle test, is negative, you can use IGRA to be sure. So IGRA is Interferon-Gamma release assay. If Interferon-Gamma release assay is positive, then rule out active pulmonary TB with history and X-ray and physical examination. You can treat as latent TB infection. If gamma release assay is indeterminate, then check your TST. If TST, that is tuberculin skin test, is positive, treat for latent TB infection. If TST or IGRA is negative, then rule out false negative. You may treat for latent TB infection based on history of contact with the affected person or the reason why the individual has been chosen for screening. Note this: healthcare workers should not be subjected to unnecessary screening if they are not working in a region with high prevalence of tuberculosis. But emergency room doctors, pulmonologists, respiratory therapists should please endure the screening. If you are highly suspicious of a latent tuberculosis infection and tuberculin skin test is negative, repeat, or you just have IGRA test after 8 weeks. But when you are repeating TST, make sure you use the other forearm, not the same forearm. BCG in the past, because we've come across this all the time, and some people will be complaining the doctor didn't take into cognizance that I had BCG when I was a child. If given BCG in the past, use IGRA today so that there won't be any argument anywhere. If the patient may not come back to have your tuberculin skin test read, use IGRA today. You could see two conditions now. If this patient had received BCG at birth and is more than 10 years, or you are suspicious that there may be controversy later on, just go for IGRA if you have it. Or this patient won't even come back for me to read the test within 48 to 72 hours, just go for your IGRA. Casual contacts may be exempted if they are not immunocompromised. Innate immunity and acquired immunity will affect the risk of the disease in the first 2 years following infection. The progress from latent TB to active pulmonary TB or miliary tuberculosis are AIDS, HIV, cancer of the head and neck, diabetes mellitus, glucocorticoids use, people younger than 4 years old when infected, cigarette smoking, tissue necrotic factor alpha inhibitors, those on hemodialysis secondary to chronic renal failure, silicosis, transplant recipient with immunosuppressive agents right now. How are we going to exclude active TB? Don't worry, just do your TST, tuberculin skin test, or IGRA. If it's positive, then have history taken, history of contact, cough, signs and symptoms of tuberculosis. Just do your physical examination, chest X-ray, then sputum. If there's cough greater than 2 weeks, some will say 3 weeks, 2 to 3 weeks, because I won't be comfortable to allow that grandpa to go home, okay, without having that test done. Fever, weight loss, night sweats, then have sputum test. The sputum should be 3 samples. The first sample early in the morning. The second sample should be taken 8 hours after the first. The third sample should be taken 8 hours after the second. When we have obtained the samples, what are we going to do with them? We can have acid alcohol fast bacilli, Mycobacterium culture, and nucleic acid amplification test done. Notice that in latent tuberculosis infection, chest X-ray may be normal. If the individual is HIV positive, you can treat for latent tuberculosis infection without symptoms. Or even when you don't have any chest X-ray or the person is not on any antiretroviral therapy, just treat for latent TB to be safe. Diagnosis. About 2 billion people, or 1/3 of the world population, are infected with Mycobacterium tuberculosis. Wow, that's pretty great. In 2018 alone, about 1.5 million people died. HIV and TB are 2 friends that are deadly to humans. Diagnosis of both HIV and TB will be saving many lives. As a matter of fact right now, I think once anybody is diagnosed with TB, the individual should be screened for HIV. If they don't want to agree, if they don't want to sign consent, you plead, or you refer to appropriate centers. People to be tested are individuals with cough greater than or equal to 2 to 3 weeks. People with fever, night sweat, weight loss, hemoptysis, and those that have been screened to have HIV also, or HIV with unexplained cough and fever. Patient diagnosed with community-acquired pneumonia but non-responsive to treatment should be screened for tuberculosis. Incidental findings on chest X-ray should warrant further screening to be sure this is not tuberculosis. Past exposure to TB or recent travel are now having symptoms similar to those with pulmonary tuberculosis. Please don't waste any further time. Screen them. When you are using sputum, sputum could be used for alcohol acid fast bacilli, or for Mycobacterium culture, or nucleic acid amplification test. If the nucleic acid amplification test is positive and AAFB is positive or negative, pending sputum culture results is not out, or any other thing happening, but NAAT is positive, then you should be highly suspicious that disease is likely. You can close your eyes and write a prescription for therapy. Let me repeat. You've taken the sputum, meant for AAFB, meant for Mycobacterium culture, and nucleic acid amplification test. your nucleic acid amplification test is positive. Whether the AAFB is positive or negative, whether you have seen the result of the culture or not, once the NAAT is positive, then disease is likely. In other words, NAAT is superior to AAFB, but culture is the gold standard anyway. If NAAT is negative, then please go and run the AAFB. If NAAT is negative and AFB is positive, it is likely the person is having non-tuberculous mycobacteria. So it could be Mycobacterium avian complex. But if NAAT is negative and AAFB is negative, then call for chest X-ray. Review the history again. Compare the symptoms and history and the chest X-ray and physical examination. If you are still suspicious, you may start your TB treatment based on all factors being considered. But if NAA is negative and you still strongly suspect pulmonary tuberculosis, obtain the second sample or sputum for AAFB, NAAT, and culture. Run the tree again. When you want to take your sample, the samples could be from bodily secretion, sputum, bronchoalveolar lavage, pleural fluid, and it could be pleural biopsy or lung biopsy. I've mentioned sputum collection the other time that is going to be 3 specimens. One sample in the morning, second sample and 8 hours later, and the third sample 8 hours after the cycle. For AFB, Mycobacterium culture, and NAAT. The skin testing will involve Tuberculin skin testing and Interferon-Gamma release assay. But note this, either Tuberculin skin testing or Interferon-Gamma release assay, if they are positive, that is not yet diagnostic. But if they are negative, that doesn't rule out pulmonary tuberculosis. Then the question is, why are we doing them? No, don't be upset. They are just going to guide us to do more or do less. Okay. In HIV with CD4 less than 100 cells, do blood culture for Mycobacterium. You can do urine culture for Mycobacteria as well. Radiological investigation could involve chest X-ray. CT scan may be useful. MRI may be, depending on how sophisticated your center is, but you don't need PET scan. No, you don't. Clinically, in up to 20%, lab diagnosis may not be possible. You then base your diagnosis on exposure or contact, history of the symptoms, physical examination, chest X-ray, positive tuberculin skin test, or Interferon-Gamma release assay, bronchoscopy specimens, and sputum, for example, hemoptysis, and histopathology. Additional info here is that you can also use pleural fluid, whole blood, gastric aspirate, and serum. Additional info will include that NAAT is superior to AFB. Culture is the gold standard. You can also have molecular testing, probe-based or non-sequencing tests. It could be sequencing-based assays, and you can use urine antigen in HIV using urine lung, that is lipoarabinoman. And with that, I've come to the end of TB Chapter 2. We'll be moving to TB Chapter 3, and that will contain all clinical features, including cutaneous manifestations of tuberculosis. Everything we need to know about all clinical features will be in the next presentation. Thanks for listening to my presentation. Kindly subscribe to my channel so that you'll be able to get all my presentations immediately they're published. I appreciate it. Thank you.